Welcome to our video on acromegaly and craniopharyngioma. Let's begin. We will discuss definition, clinical features, complications, diagnosis, and management of acromegaly. Acromegaly results from excessive secretion of growth hormone in adults. This is most commonly caused by pituitary somatotroph adenoma. Before we dive further, let's review some basic concepts. GHRH, produced from hypothalamus, stimulates GH secretion from anterior pituitary. On the other hand, somatostatin inhibits GH secretion. Some factors that inhibit GHRH production and thus GH production are glucose and obesity. Other factors that stimulate GHRH and thus GH production are hypoglycemia and stress. When GH is produced, it stimulates IGF-1 production from the liver, which is responsible for most of the GH effects in the body, such as stimulating linear growth and increasing muscle mass. Growth hormone also has other direct effects. For example, it increases lipolysis, and it has anti-insulin or diabetogenic effect. A pituitary somatotroph adenoma causes oversecretion of growth hormone, which in turn leads to overproduction of IGF-1. Many of the clinical features result from overgrowth of bones, cartilage, and other tissues. Overgrowth of tissues is mainly related to the excess levels of IGF-1. Tissue overgrowth can result in findings like coarse facial features, enlarged hands and feet, macrognathia, arthalgia, macroglossia, voice deepening, and enlargement of organs such as heart and thyroid. Remember that macrognathia is the abnormal enlargement of jaw, and macroglossia is the abdominal enlargement of the tongue. In addition, oversecretion of growth hormone and IGF-1 causes metabolic effects. Most important is insulin resistance. Pituitary adenoma can cause mass effect symptoms, particularly when it is large enough to compress local tissues. These include headache and visual disturbances. Here is an image showing a patient with acromegaly. Note his coarse facial features, macrognathia, and enlarged hands. Here is another patient diagnosed with acromegaly. Note the prognathism, which is protrusion of lower jaw. Note also the jaw malocclusion, and this is caused by overgrowth of mandibular bone. This image shows a hand of a normal person in comparison with the hand of a patient with acromegaly. Note the enlarged hand with the thickened and fleshy fingers, which are commonly seen in acromegaly. Before we move on to diagnosis, let's discuss some important complications of acromegaly. They are generally caused by excessive production of growth hormone, overgrowth of tissues, as well as enlargement of visceral organs. For example, carpal tunnel syndrome may occur. GH excess increases the retention of sodium and water in the extracellular fluid, so the edematous synovial tissue compresses the median nerve, leading to symptoms of carpal tunnel syndrome. Obstructive sleep apnea is another potential complication. This results from macroglossia, enlargement of soft tissues of pharynx and larynx, as well as the craniofacial deformities associated with acromegaly. When it comes to the cardiovascular system, acromegaly can lead to hypertension due to GH-mediated increase in renal sodium absorption and sympathetic nervous activity. Hypertension, in combination with the direct effects of GH on the myocardium, can result in left ventricular hypertrophy. This can subsequently lead to heart failure. Valvular heart disease, such as mitral regurgitation, may also be present in acromegaly. This is likely related to the abnormal extracellular matrix regulation seen with excess levels of GH and IGF-1. Colon polyps are among the complications affecting the gastrointestinal system. They likely develop due to the IGF-1 effects on the proliferation of the epithelial cells. Additionally, colonic diverticula may be seen in acromegaly. This is likely related to the effects of GH and IGF-1 on extracellular matrix and collagen metabolism. As we mentioned earlier, excessive growth hormone plays a role in insulin resistance, so this can be later complicated by secondary diabetes mellitus. You should be aware of these complications as they can be tricky presentations on vignettes and exam questions. Here is our algorithm of acromegaly. We will follow with it as we discuss diagnosis and management. So let's begin. When suspecting acromegaly, the best initial test is measuring IGF-1 level. Remember from step 1 that IGF-1 level is consistently elevated in acromegaly. On the other hand, GH level can largely vary throughout the day, so it is not useful for diagnosis. Normal IGF level excludes diagnosis of acromegaly. Elevated IGF-1 confirms a diagnosis of acromegaly. If IGF-1 elevation is uncertain or equivocal, we move on to oral glucose suppression test. When the test is positive, meaning that oral glucose load does not suppress serum GH adequately, then the diagnosis of acromegaly is confirmed. The next step is MRI of pituitary region to look for the expected adenoma. Be aware that imaging studies should be performed only after biochemical testing confirms the diagnosis of acromegaly. The presence of a pituitary mass on MRI confirms the diagnosis of GH-secreting pituitary adenoma as the cause of acromegaly. However, if the pituitary looks normal on MRI, we should look for extra pituitary causes. Here is an MRI of a patient diagnosed with acromegaly. Note the pituitary adenoma with suprasellar extension that compresses the optic chiasm. Before we end with management, let's try a quick question. A patient that is previously diagnosed with acromegaly presents to the office complaining of shortness of breath on exertion. It started 3 weeks ago and got worse over time. His history of cardiopulmonary disease is insignificant. What is the most likely finding on echocardiogram? So we have a patient diagnosed with acromegaly. He complains of worsening shortness of breath on exertion. We know that acromegaly can lead to left ventricular hypertrophy, which is exacerbated further by hypertension that is likely to be found in acromegaly as well. Diastolic dysfunction can ensue, and a patient can present with fatigue and worsening dyspnea on exertion. So the most likely finding on echocardiogram of this patient is concentric left ventricular hypertrophy, and this could be complicated later by heart failure and arrhythmias. Moving to management. Mostly all patients with acromegaly due to GH-secreting pituitary adenoma need to be treated even when the adenoma is asymptomatic. Preferred initial treatment is transsphenoidal surgery. However, medical therapy can be considered first if the adenoma is largely unresectable or there is a high risk of surgery. If surgery is performed, but the IGF-1 and GH levels are still elevated and there are moderate symptoms of GH excess, then medical therapy should be considered. Somatostatin analogs are usually used, such as octreotide. If they are ineffective, pegvisomant, which is a GH receptor antagonist, can be used alone or in combination with somatostatin analogs. Radiotherapy or repeating surgery should be considered when medical therapy fails. Finally, let's discuss our last topic here, craniopharyngioma. We will discuss definition, clinical features, diagnosis, and management of craniopharyngioma. It is a benign tumor arising from embryological remnants of Rathke's pouch and forms a sellar mass. Before we continue, let's get back quickly to embryology and formation of pituitary gland to remember what Rathke pouch is. We know that posterior pituitary arises from neuroectoderm of diencephalon, and anterior pituitary arises from oropharynx ectoderm, which forms what is called Rathke pouch. So neuroectoderm comes downward and Rathke pouch comes upward to come together and form the pituitary gland that sits in the sella turcica and has a posterior lobe and anterior lobe. Getting back to our slide, craniopharyngioma commonly has mixed solid and cystic components. Typically it grows slowly over years. There are two incidence peaks, one in children between 5 and 14 years and the other in adults between 50 and 75 years. As craniopharyngioma compresses local tissues, it leads to mass effect symptoms such as headache and visual field defects. It can also lead to hypopituitarism when compressing normal pituitary cells. For example, growth hormone deficiency leads to growth failure in children, and deficiency of gonadotropins leads to sexual dysfunction in adults. Neuroimaging is used to confirm the diagnosis. This includes MRI or CT. In most cases, craniopharyngioma can appear as a cystic calcified lesion in the parasellar area. The preferred initial management is surgical resection. Radiation therapy is considered when there is residual tumor or recurrence occurs. Here is a head MRI of a patient diagnosed with craniopharyngioma. Note that this tumor has cystic and solid components. Here is a CT image of another patient diagnosed with craniopharyngioma. Note the calcified cystic lesion in the suprasellar region. Now let's end this lecture with a question. A 10-year-old boy is brought to the physician by his mother due to severe headaches for the last 6 months. Headache commonly wakes him up from sleep and is more severe in the mornings. He also complains of decreased vision. The ophthalmological exam reveals bitemporal hemianopsia. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 110/70, heart rate of 91, and respiratory rate of 14. Brain MRI shows a calcified parasellar mass with solid and cystic components. Which of the following is the preferred management option for this patient's condition? A. Chemotherapy. B. Radiotherapy. C. Surgical excision. Or D. Observation. This patient presents with headache for the last 6 months. The headache commonly wakes him up from sleep and is more severe in the mornings. This pattern of headache suggests an increased intracranial pressure due to a space-occupying lesion. This is because the supine posture decreases the cerebral venous drainage, raising the intracranial pressure. If the patient also has a space-occupying lesion, then the intracranial pressure increases to the point that the headache wakes the patient up from sleep. Bitemporal hemianopsia on the ophthalmological exam indicates that the intracranial mass compresses the optic chiasm. Brain MRI shows a calcified paracellular mass with solid and cystic components. This is the classic description for craniopharyngioma. The preferred management option for craniopharyngioma is surgical excision. Therefore, the correct option is C. Here is the slide reminding us of the diagnosis and management of craniopharyngioma. Let's discuss why the other options are incorrect. Option A, chemotherapy, is incorrect because it's not typically used in the treatment of craniopharyngioma. Option B, radiotherapy, is incorrect because although it's used to treat craniopharyngioma, it's not the preferred management option and is considered for residual tumors or recurrent cases. Finally, option D, observation, is incorrect because this patient is symptomatic and needs prompt intervention. And that concludes this lecture on acromegaly and craniopharyngioma.